Hello everyone, I'm Dr. Michelle Hawkins. Today I'll be giving an overview of viral infections of the skin. There are several common viruses that cause skin infections, namely herpes simplex virus 1, which causes the fever blister or cold sore, herpes simplex virus 2, which causes genital herpes. We'll also talk about the varicella zoster, which causes chickenpox in children and reactivates to cause shingles in adults, also known as herpes zoster. We're going to talk about the HPV virus, which has many subtypes, and that causes verruca vulgaris, otherwise known as common warts, and we'll talk about plantar warts. We'll also talk about condylomata acuminata, also known as genital warts, and we'll talk about verruca plana, which is known as flat warts. Lastly, we'll talk about molluscum contagiosum infection, which is caused by the pox virus. HSV1 and 2 are the most common viral infections in the world. In fact, 90% of the population of developing countries are thought to have an infection with HSV1. HSV1 is more common than HSV2. It causes an orolabial HSV infection, although HSV2 can also cause an orolabial infection. HSV2 is the most common cause of genital herpes, although again, HSV1 can be the culprit in genital herpes as well. HSV1 and 2 infection can be recognized as painful grouped vesicles that appear on an erythematous base, initially having a clear or serous fluid, but then become cloudy and develop a purulent type of fluid. They then erupt and form erosions or ulcerations on the skin and have a typical punched out appearance, otherwise a scalloped border. The lesions can be preceded by a prodrome of an area of tingling, burning, or painful sensation before the lesions appear clinically. Here we can see a typical presentation of HSV1, which occurs above the belt, and you can see these punched out ulcers which have an erythematous base surrounding it, and they appear to be clustered. This will often happen on the lips and nose, but it can happen anywhere above the belt. This is a typical presentation of HSV2 infection. As you can see, there's a genital distribution of these punched out lesions with a surrounding erythematous base that would typically be rather painful. They can become widespread and you have this large area of ulceration, particularly in immunocompromised patients. Treatment of HSV1 and 2 is with oral antiviral medication, as topical antivirals have been shown to have minimal effect. We use a cyclovir suspension for children at 15 milligrams per kilogram 5 times a day for 7 days. We use a cyclovir 400 milligrams 3 times a day for adults for 7 days. In refractory or recurrent infections, we use valcyclovir 1 gram twice a day for 7 days, or we can use famciclovir 500 milligrams twice a day for 7 days. This medication reduces the duration of the illness by more than 50%. The varicella zoster virus causes varicella zoster, aka chickenpox, as part of its primary infection, most commonly in children. The incubation period is 10 to 21 days. That means from the time of infection with the virus to the time that signs and symptoms appear. Transmission is via the respiratory route and sometimes by direct contact with the lesions. The clinical features include a low-grade fever, lethargy, loss of appetite, malaise, and a headache, which are usually present although mild. The patient will note a vesicular eruption that appears as a droplet or a teardrop on an erythematous base. These vesicles initially start on the neck and face and trunk, and they spread peripherally to involve the limbs to a lesser extent. There can also be mucosal involvement of the conjunctiva and the mouth. Here we can see a typical varicella zoster infection where you can see these droplet vesicles that are cloudy and have a surrounding erythematous base. They are often at different stages of development. As you can see, some of them have newly appeared and others already have ulcerated or been excoriated. The treatment for chickenpox is most effective in the first 2 days of clinical signs and symptoms. We use acyclovir 800 milligrams per os 4 times a day for 5 days. We can also use valcyclovir 1 gram 3 times a day for 5 days, or for severe fulminant disease with visceral complications, we can use IV acyclovir. Next, we'll talk about herpes zoster, which is also known as shingles. Here we can see the typical appearance of these very painful vesicles that are clustered on an erythematous base. Of note, they are occurring in a single dermatomal region. Herpes zoster is caused by the reactivation of varicella zoster virus. What would typically happen is that a child will be infected with varicella zoster virus and get chickenpox, or would be vaccinated for varicella zoster virus. Upon healing, the varicella zoster virus remains latent in the dorsal root ganglions of the spine, and then 10 to 20 years later, when you are immunosuppressed or if you are elderly, there would be reactivation of the varicella zoster virus such that you get a herpes zoster infection or shingles infection. Herpes zoster or shingles begins as an area of tingling sensation, numbness or pain in a dermatomal distribution, which after a day or a few days leads to an erythematous eruption with papules that coalesce into plaques and within hours form vesicles in that dermatomal distribution. This is often a very painful condition. As I said, the pain can precede the rash, or the pain can happen a few days later. The treatment for herpes zoster is with acyclovir 800 milligrams 5 times a day for 7 to 10 days. Alternatively, we can use famciclovir 500 milligrams 3 times a day for 7 days, or valcyclovir 1 gram 3 times a day for 7 days, which we would often use in fulminant or recurrent condition. Now let's talk about the HPV virus, which is a common culprit for several skin infections. Verruca vulgaris is otherwise known as the common wart, which is common in children. It generally occurs on the hands, although with autoinoculation, you can spread it to other parts of the body. Typically, these lesions resolve spontaneously. Here we can see the verruca vulgaris, or common wart, which can be described as a grayish, tan, or flesh-colored verrucous papule, which are commonly found in numbers. The HPV virus also causes plantar warts, which are warts underneath the plantar aspect of the foot. HPV 1, 2, 4, 27, and 57 cause plantar warts. These generally appear on the pressure points of the foot, such as the ball of the foot, but they can also occur on the arch of the foot and on the heel of the foot. They can be confused with corns and callosities, but you can differentiate them from the appearance of a central umbilication, and also when they are cut with a razor, you find that there are pinpoint capillaries. This is something that calluses and corns don't have. The treatment for common warts and plantar warts involves destruction of the warts to induce a local immune reaction. We use cryotherapy as a first-line treatment to burn the center of the wart, and that induces a local immune response. Alternatively, you can also use destructive lasers or surgical excision. Topical agents that irritate the lesion and cause an immune response include salicylic acid, lactic acid, and cantharidin. Genital warts are caused by more than 30 HPV types. The most common low-risk genital HPV types are HPV-6 and HPV-11. And the most common HPV-induced genital dysplasias are caused by HPV-16 and HPV-18. Generally, all genital warts are benign and caused by HPV-6 and 11. Infection with HPV is strongly associated with sexual intercourse. So if you ever see a child with genital warts, you should have a strong suspicion of sexual abuse. Condylomata acuminata, or genital warts, appear as lobulated or verrucous, hyperpigmented or tan, flesh-colored papules. Although they may typically be 2 to 5 millimeters in size, they can also become much larger and very extensive. These are frequently multifocal. In other words, they occur in several different regions. Here we can see extensive infection with these hyperpigmented verrucous papules that are found on the inner thighs, on the prepuce, on the penile gland and the scrotum, as well as in the perianal area. Again, with these type of warts, we use topical or other invasive methods to irritate or destruct the lesion and thus elicit an immune response. We often use podophyllin, 25% solution, weekly for 6 weeks. Alternatively, podophyllitoxin, 0.5% solution, which is applied twice a day, Monday, Tuesday, Wednesday, i.e. 3 days a week for 4 to 6 weeks. We also commonly use imiquimod or Aldara 5% cream, Monday, Wednesday, Friday for 6 weeks. But the most effective treatment is cryotherapy, where we use liquid nitrogen from a spray gun to destruct the lesion. We can also use electrocauterization, which is when you use a diathermy to burn the lesion. Other options, which we don't commonly use, include 5-fluorouracil, which is otherwise known as Effudix, TCA, which is your trichloroacetic acid, CO2 laser, and intralesional interferon. These are not as accessible because they are costly. Verruca plana is another common viral infection that is caused by HPV virus. As we can see, it's visualized as these fine, flat-topped, red-brown or hyperpigmented papules that commonly occur on the face and on the trunk. Verruca plana is caused by HPV 3, 10, 28, and 41. It's common in children, teenagers, and young adults, and is aggravated by sun exposure. The treatment of flat warts is with topical medications such as retinoids or tretinoin, tazarotene. We also use topical salicylic acid or 5-fluorouracil, 5% imiquimod, which is Aldara, PDT, electrodesiccation, and topical immunotherapy. These are irritants, again, that elicit an immune response from the patient, which will take care of the infection. Otherwise, we just observe as these lesions tend to undergo spontaneous remission. Lastly, we'll discuss a very common infection, which is called Molluscum contagiosum. Molluscum contagiosum is caused by the pox virus. It's common in young children, adults who are sexually active, and people who are immunosuppressed, especially those who have HIV. Molluscum contagiosum is transmitted by direct skin-to-skin contact, especially if the lesion has been broken and if the skin is wet. Individual lesions are described as these shiny, firm, dome-shaped pearly papules that have a characteristic umbilication in the center. They average 3 to 5 millimeters in diameter, but you can also get these giant lesions of up to 1.5 centimeters in diameter, particularly in immunosuppressed patients. The treatment of molluscum contagiosum is similar to the treatment of warts in that you want to destruct the lesion and elicit a local immune response. So we use topical tretinoin or retinoids. We also use cantharidin. You can lightly spray with liquid nitrogen as cryotherapy, or you can curettage the lesion with a razor blade. We also use TCA and 5-fluorouracil. In young children, especially those who are immunocompetent and those who we expect to spontaneously resolve, we can also just not treat, as most of these lesions will resolve by themselves within a year or maximum 2 years. Thank you guys for listening to my overview of viral infections of the skin. If you have any questions, just drop them below and I'll get back to you.